I think any researcher will tell you that one of the best parts of our job is when you get to see your research translate into actual change. Now, I was lucky to have that happen to me in a big way back in June of 2025 when the province of Ontario passed the Primary Care Act into law. A set of 6 priorities for primary care that directly reflect the 6 elements of the Our Care standard. That standard was a distillation of everything we heard from people across the country on what they wanted to see and what they expected from a primary care system. And it's been great to see that even just this month, Ontario's health minister announced the government is on track to increase access to primary care to all residents of the province by 2029. Now, that best part I talked about also came up a few months ago when I heard Nova Scotia's Dr. Nicole Boutilier reference in a presentation how they've used the Our Care report from their province to center the patient voice in their provincial primary care reforms. In our last 2 episodes, I took you on a journey to Costa Rica to see how that country is integrating primary care and public health and really using a community-based approach to deliver care with geographic empanelment and community health workers who are really leading the way. Now, we're going to talk more about community-based primary care in a couple of future episodes. We'll take you to clinics in BC and Ontario to talk about the innovative work they're doing in this area. But after hearing Dr. Boutilier talk about Our Care's impact on Nova Scotia's primary care policies, I thought we'd better take a brief detour to talk about how that province's primary care transformation has Our Care at the center. And so today, I talked to Dr. Boutilier about how they're building new pathways for patient access, all with the patient voice at the center. Welcome to Primary Focus, a launching point for a national conversation we really need to have about the current primary care crisis in Canada and how we're going to solve it. I'm Dr. Tara Kiran, a family doctor, researcher, and an advocate for a better primary care system in this country. I believe in creating a primary care system that's inclusive, comprehensive, and that truly works for everyone. But to do that, we're going to have to make primary care our primary focus. So today on the show, Dr. Nicole Boutilier, the Executive Vice President of Medicine and Clinical Operations for the Nova Scotia Health Authority. Here's Nicole.
I am a family doctor by training and did my residency in Calgary. So I've done a variety of things. When I lived out in Alberta, I did full scope family medicine in a rural, very rural setting. At that time, it was about 3,000 people with a local hospital. And I did emerge and inpatient and office and obstetrics. I also did some work at Siksika First Nation at the time and did some outreach clinics there. And I do have 3 children, and I started having children, and I got the call to come back home and be closer to family and that. And when I moved here, back here, I started doing full-time emerge. And I did full-time emerge for a number of years. And then as I started to weave more back towards more leadership experiences, I started doing some locums in the collaborative settings and also working at youth health centers. And that's been kind of how I've kept my feet in the door with family medicine through the years.
Nicole is a family doctor leading primary care transformation in a government role, which is more rare than you might think. And in this conversation, we cover a lot of ground. We talk about how Nova Scotia has reformed their Need a Family Practice Registry, a centralized waiting list of people who need primary care that's managed by the Central Health Authority. She details how they're connecting people to new primary care teams called health homes and supporting those teams to work effectively together. We also dive into the options they've built for people who don't have a family doctor so that those people can access care while they're still waiting for one, and how a new physician payment model called the Longitudinal Family Medicine Payment Model, or LFM, is making family medicine more attractive. We also talk about how Nova Scotia is training the next generation of family doctors through a unique new medical school focused on training rural family doctors who commit to practicing in the province. And importantly, how they're empowering people in Nova Scotia to have access to their own records through a new app, Your Health Nova Scotia. Here's my conversation with Nicole. Nicole, welcome to Primary Focus. It's so wonderful to have you here.
Oh, I'm excited to be here. Thanks for having me.
I invited you on this podcast because of a presentation I heard you give a few months ago. I was really struck because you and I had actually never met before, but you started and you ended the presentation talking about how the patient voice was so central to the work that you were doing in Nova Scotia around primary care transformation. And you specifically cited the Nova Scotia Our Care Report, which I was delighted to hear. And I was wondering if you could just go into it a little bit more about how that Our Care Report has influenced the direction of your work in Nova Scotia.
I think, too, I should say that I didn't know you were going to be in the room and I wouldn't have even connected it probably. So it was totally a coincidence. So I think that, genuinely, that's where we started. We had this wonderful opportunity to make investments and changes in primary healthcare. And we already had something that told us all we needed to know. And we were very aligned as a leadership group as well with the Our Care standards, like what you heard, what we felt from working in the system. So it was like not even a second thought that we kind of put that up as this is what we want to try to achieve. We might not achieve everything in there, but we're going to start working towards it and, making sure we're focused on what patients and providers told us. When do you have an opportunity to have sorts of national survey and then all the focus groups and right down to like groups that were important to us in Nova Scotia, like our patient family advisors, our leaders, like they all took part in it. So it was very, connected us right from the start, and we continue to update our thinking as that evolves as well and make sure we're still aligning and, we can bring it back to that. And when you can bring it back, anything that you're doing, any kind of changes, both for providers and the community, when you can ground it in what they want and what they've told you and making sure that that's coming first, it's hard to misstep if you keep that as, your main focus.
Yeah, that's so wonderful to hear. I have to say our Nova Scotia group was among the most engaged. The patients and public we worked with, they created their own Facebook group, I think, after to try and stay in touch. And, it had a very kind of family-oriented feel, I think, is a way, everyone is very friendly in Nova Scotia. It's a stereotype, but I think it's also true. And so I know that some of them will be listening. And so I'm sure that they're going to be heartened to hear how the real hard work that they put in and the time that they put in as volunteers has made a difference and that you have heard their voices and continue to go back to them. I was wondering if you could give some examples of decisions your team has made as a result of the Our Care consultations or the Our Care report and what were in the recommendations.
Sure. I think pretty much everything we've done connects back to it somehow. But when you think about attachment, when we started to really dig in our attachment rate, there was about 16% of the population here unattached. Numbers off the press now, we're getting under 7% and we're still going and we're still doing that. So there was many things around that we needed to do differently. We had the fortune or misfortune, depending on how you look at it, at knowing the numbers and knowing the people that were on the list, but that's all we knew. We did not know what they were waiting for. We did not know what their access was otherwise. We did not know the state of, had they just had a doctor or has it been 10 years? There was nothing we knew. So we sought out to actually really redefine that and create a tool with the Native Family Practice Registry that would be more of an interactive tool where we would gather information around age and demographics and preferences, their current health status. We also have sort of like an emergency category. So if people were pregnant or in need of regular care because of a new diagnosis, there was also a way that they could step into that. So part of it was to promote attachment. The other piece of it is really to promote stabilization and really working with providers in their offices to either add care team members, add resources that would help new practitioners on board, or, just that support that people are missing when they're out in the community and feeling like, oh, I'm walking away from family medicine because this isn't working for me. So we created a physician hotline and we kind of set out to make it so that no one would ever leave It didn't mean that they necessarily won't move on to other things, but they weren't going to leave unsupported and with their patients unsupported. The other piece is that we really focused on, attachment is important and access is important. And we know even some people with attachment didn't necessarily have great access. So we've created about 1 million appointments in different types of access, whether it was virtually, whether it was mobile clinics, whether it was in pharmacy offices, whether, it was just an expansion of some of the services that we already had. And that piece to give patients access while they were waiting for that attachment is really critical to what we were doing, because we needed to know that people were getting care. The other piece that we have are called primary care clinics, and they are an in-person solution to people that don't have attachment. For instance, if you access Virtual Care Nova Scotia, which is provided by all Nova Scotia providers, they can refer to an in-person appointment if needed through our primary care clinics. And then the person stays with the primary care clinic as long as they need to after that point. And it also, if people need things done that are typically only done by family doctors in their offices, like maybe allergy testing, or maybe they need a comp forms filled out. Maybe they need to have a physical for a job or something like that. So we've created pathways that even while we wait for attachment, because we knew we weren't going to go from 16% to 0, we needed to have a path to get there. We were trying to look at all the ways that we could have primary care access as robust as we could. And, again, that also touches back to our care report, because patients were telling us about their need for virtual appointments.
I think what I'm hearing you say is, that your overall goal is to have everybody in Nova Scotia have access to ongoing primary care, but that it's going to take a bit of time to get to that 100%. And as we are getting there, you've tried to put in other methods or other ways in which people can try and get some access until they have that ongoing relationship, is what you describe as attachment, or I think that's often what we in the healthcare world talk about as attachment, which is really that ongoing named family doctor or clinic or nurse practitioner who's going to be able to see you on an ongoing basis. And so maybe I'll just start with the your drive for getting everybody a family doctor, nurse practitioner, or clinic. What are some of the strategies that you've taken to try and get that attachment? You mentioned some of it is stabilizing the workforce, but I think there have been other strategies that you've used as well.
Yeah, so there's the stabilizing for the work by providing support, but it's also enhancing that workforce and really looking at how other providers can all work as a team together, and really embracing the health home model that the Canadian College of Family Physicians and others have advocated for in creating team-based care. And what we did learn there is just because you put people together doesn't mean that you have a way of doing team-based care. So we've been actually really intentional about how these clinics will be monitored and run and assessed, and the kind of things that we would like to see happening in all the health homes, and really creating an environment where the team and their skill set, everybody in that skill set, is working to their full scope. So a lot of work done on people and full scope and being able to practice full scope, and really also on the relationships between the team members and how they best serve patients. And I think that's been another good strategy. The other one is about space, like physical space, like creating health home environments through physical space that is conducive for group appointments, or conducive for multiple team members being co-located. And one of our newer ones actually has a purpose-built for primary healthcare sim space where people can all learn from the interprofessional team for different skills and learn together things that are coming down. So that was really exciting for us to even push the limit on, what we can create in these sort of what we called layered learning environments, where we have lots of students, lots of professions, and lots of patients, and everybody working together to get the best care possible.
Yeah, I love that. I mean, physical space really is important. I think the literature shows, and my own experience is the same, is that, when people are co-located, and depending also on the way that specific structure is designed, if there's an ability to interact among team members, it can really enhance the way a team works. I'm curious if you could just expand a little bit more on the teams you describe. What portion of the Nova Scotia population do you think has access to that kind of team-based care?
There's a variety of setup, and we've kind of had those core team members. We've defined core team members for optimization that you need to have. And then on top of that, we've looked and listened to the individual community as to what that community needs. What are they missing in their community? So we have the optimal team members and then additions. So not everyone looks the same. Not everyone has all the members. And they're always kind of looking at, oh, we're working really well at this phase. We're doing good. We can serve our patients well. And then, or they're saying, wow, would it ever be great to have a pharmacist here one day a week? Would it ever be great to have mental health come in? How can we collaborate with some of our community resources a little better? So that is really what we want, is creating those health homes that then start to become a health neighborhood. And for the communities that they're in, Nova Scotia is we have rural communities. So this is about rural medicine as much as it is about anything, because creating full functioning spaces for people in a community, especially a rural community, to access other services that they might not otherwise have had the ability to do so through the community is also critical.
I love that there's standardization, but with the flexibility to meet community needs. I'm curious what your core team members are. What have you decided on for that?
Yeah, so we do have a few different iterations too, depending on what we're starting with. There's physician NP interchangeable models, and there's physician and NP models, family practice nursing, admin support, like for the clinic, and what we call a primary healthcare lead, who's maybe has more than one clinic, but is actually like helping them achieve their goals. We have supports from external teams for those teams, like the onboarding team. We have the rapid onboarding team, which would also be like a group of some nurse practitioners and that would come to the clinics and work on onboarding. We also have a practice support team. So if there's issues that are improved, like some of the projects they did, like one of the ones I really loved was around the EMR, where they came in with like some basic things there that allowed them to flourish and practice faster.
One of the recent episodes we did this season was with Isabelle Gabory in Quebec, and she talked a lot about the supports that teams need in order to be high functioning and work well together. You can't just throw people together and expect that they are going to work as a team. And so, I think you've talked already about some of the implementation supports that you've put in place to support these 117 teams that you have in Nova Scotia. And I wonder if you could tell us a little bit more about what those implementation supports look like.
Well, there's leadership supports, I guess, and there's also the co-leadership, like the clinical co-leadership in the clinics.
Yeah. And then I think you have some learning collaboratives and coaches and things like that too.
Yeah, what we call QI collaboratives. And really that's about, if they sign on to be part of a collaborative, they really get support about how to do QI. And we have kind of a well-prescribed program that they would go through with that support from, there's teams that would coach them through that are part of the quality team. And really it's also about spreading that, like, so that we don't just create, a one and done type of thing, that we people keep learning and they can become coaches after they've gone through the collaborative.
I think I remember you also telling me that you have people that actually come into the clinics to observe and understand kind of the efficiency in the clinic and the different roles people are taking. Tell me a little bit more about that.
Yeah, so we had transformation teams. Again, this was like for transformation broadly, but like some of the people that would be on that team would be like data analysts, industrial engineers, interprofessional practice and learning, maybe research and innovation. And we would just assemble whatever that team is and go into a clinic and maybe watch the flow, try to optimize the space, make suggestions about space changes or process changes that could really benefit that clinic.
Yeah, I think that that's really important. I mean, I think as we think about accelerating team-based care as a way to improve primary care, there's a few different rationale. Of course, patients love to have access to different healthcare professionals, to have like a more holistic care, to look after the different parts of themselves in a more comprehensive way. I think many clinicians love it because, it adds, as you said, support to their day. Who doesn't love having other people to help them to really think about the complexity that often is in our day? But I think one of the main reasons that we need to move to team-based care in Canada is we just don't have enough doctors and nurse practitioners to actually go around. We don't have enough doctors and nurse practitioners to serve the population, given the way that we have worked traditionally. What we need to unlock as a country is how do we use teams to support doctors and nurse practitioners to actually care for more patients. And I think one contentious area is, when a doctor works in a team, should there be a minimum number of patients that they should be expected to care for, given that they do have access to other health professionals? And I'm curious, what your approach in Nova Scotia has been to that. Are there kind of minimum numbers of patients? Do doctors have kind of roster targets? And if so, how are those set?
How we've done this is in collaboration with Doctors Nova Scotia and the Department of Health and Wellness. And basically, when we negotiated the last contract, we had all these conversations, and there was a co-design of what we call longitudinal family medicine, LFM. So we have target panels, but people don't have to do a target panel practice. If you want to do 60% of your time in your office, you can also do hospitalist work. You can also do other types of work that rural communities need. It doesn't prescribe that thou must do this, but there's a certain salary associated with a full scope office practice. People are doing really, really well, and people are choosing it. Like, we've seen like a ton of people choose to become on the LFM. So it's been really a really big success.
You mentioned Virtual Health Nova Scotia, which is something else you put forward as a way to enable access for people as they're waiting for that permanent attachment or that named family doctor, nurse practitioner, or clinic. And I was just wondering, how you guys are also approaching that. I think people want access to virtual care, but my understanding from talking to patients is often they would ideally want it in virtual, integrated with in-person care, but also with continuity of information. And so I think one of the things that some of our research has pointed out is, often when people are using virtual-only platforms, then there can be sometimes downstream consequences for the health system with more use of, for example, the emergency department. And, we think some of that might be related to just not having what we call informational continuity or access to people's records when you're seeing them, and, not being able to follow up on an ongoing basis. And I'm curious kind of what thinking you guys have done around this area of continuity to prevent fragmentation that I think is a big risk when you think about one-off virtual care.
Yeah, so there's kind of two answers to this. So one would be the fact that we've granted virtual care in Nova Scotia in both people that don't have access to regular care and also in Nova Scotia practitioners. So they have a direct path to in-person care if they need it. And then they would get the continuity of, if it was a diagnosis or a problem, and they can stay there until they have a doctor. So that's one way of like connecting them to in-person care when needed. And we have pretty steady results that about 30% of people need that.
Okay, so 30% of people accessing these virtual appointments are eventually also referred to these primary care clinics that then follow them on an ongoing basis.
Yes. Then the second piece is about having the patients have autonomy over their data.
Yeah, let's talk about that.
Yeah, so we also have something digital called YourHealthNS. It's an app, and people can find their patient summary there. They can find their test results. They can find appointments. They can find ways to access like women's clinics or other community sports, mental health supports. There's also a bit of an AI chat tool that they can say, like, where are the best things? Oh, you have a pharmacy open today in your area, that you could get the help for that problem with. So it's kind of has help for patients to navigate the system. And it also has help for them to be the owners of their data that they can provide to others. Like they can share it. They can actually share what they see. Like the code, they don't have access forever to them, but they can give them access when they're in front of them. So they actually can share with a provider that they want to share with.
I mean, it's amazing because I will say when we, again, talk to patients and the public across the country, one of the things we heard over and over again is how frustrated people were that they didn't have access to their own health records. It obviously has huge implications from a patient safety perspective, from being able to, get care even across provincial boundaries, or even sometimes within the same province for, people to have access to important diagnoses, for if you go to the emergency department for them to know what medications you're on. So we heard so many examples of how not having access to your own record can really detrimentally affect your healthcare. And so it's amazing to see that you guys have launched Your Health Nova Scotia. For those of you who aren't familiar with it, it's an app. So it's something that you can access on your phone. Maybe you can also access it online, but I've only seen the phone-based pictures. It seems like to me that you can access a lot of your different parts of your health record. I was wondering if you could go over what are the different parts of the health record you can get through it, and are primary care records included in that right now?
I looked at mine because everybody wants to see what yours look like. And so it had a few hospital visits I had. It had all my immunizations on it. It had any blood work I'd had done. It had x-rays and anything like that I've had done. It had kind of a summary of the facilities I had visited, and just like the overall, like kind of what you would see on the first page of a chart, like with just the demographic pieces as well. So, and medications and your medication history, like what you started and stopped and things like that. Allergies, there was a lot on there. And when you see a patient, like even in an emergency setting, and like sometimes you're like going to the trauma room or going to something else, and by the time somebody gets the paper chart and things like that, it wouldn't have all that. I did all this in the community as well. While it doesn't have your family doctor notes on there, it has like all the appointments and things that you've had recently. And, it was a fairly decent summary if you're just coming online, like a fairly lengthwise too. Like it went back far enough that you get the sense of how somebody's health was over the last while and things like that. So I think it like a useful tool for a patient to be able to provide that to their doctor that they might be seeing in any setting, not just like a virtual care setting, but like, Emerge and other settings too. And it's very helpful because I'm sure you have too had this experience of having to call for the chart, having to call the family doctor's office, having to call the pharmacy, having to call like another DI department and things like that to try to get those things quickly.
Absolutely. I mean, I think the medications alone is a huge piece because people are on a lot of medications these days, and you could have different prescribers. And it's important, for example, as a family doctor, that I know what medications were prescribed in the emergency room or by a specialist. And I don't always have that information in a timely and accurate way. And that can be a big issue from a patient safety perspective, but also from a disease treatment perspective. So absolutely so important to have that information and have patients have ownership over it. I'm curious how you did it, though. I'd say what you describe is actually an aberration when we think about Canada as a whole and what's happening in every province and territory. What Nova Scotians have in an app is not the standard across the country. So how did you make it happen? And who were the people who were potentially opposed to it, if you can say, and how did you kind of get them on board?
Really, it was about data and what they could accumulate and put on the cloud and figure out what it was. So it was a lot of working with government around what that looked like from their perspective. There was lots of engagement and consultation with Doctors Nova Scotia around data points and things like that. So I would say that change is always hard, no matter what it is. But when people start to see the power of things and how it works. And it was like, we're really cautious. There was like a pilot done around like starting to give test results, and there's a lag in the test results, so the family doctors have time to review and things like that, and really like working with the different providers to do it. And it was challenging. Like, those things are challenging, and it's really about bringing everybody to the table and working through those problems. And I mean, there's lots of other things that YourHealthNS could do that they aren't doing right now today. And like, to get to every stage of that plan, it'll have to keep being about engaging, and, and then good implementations and, evaluations afterwards, seeing how it's working, and willing to be nimble around changes is, I think one of the things that we have really learned how to do.
Yeah, I love that. So we talked about a lot of the initiatives. I mean, I think a couple of things we haven't talked about that I think are also things that you guys have pushed forward was a new medical school. And then also, I think you guys have a pretty unique international medical graduate assessment clinic. And I wondered if you wanted to speak to those two initiatives or anything else that we haven't touched upon in terms of your transformation.
Yeah, no, those two things are great examples. The new medical school opened up in August in Cape Breton. And what's unique about this medical school, it's being delivered at Cape Breton University and is associated with Dalhousie University Medical School. They have 30 students that are going to come in every year, and these 30 students are going to be family doctors. They're going to do family medicine residency, and they're going to be committed to the province of Nova Scotia. A lot of people said it couldn't be done. It's been done really quickly. And I was fortunate enough to attend the Rising Tide ceremony, which was their opening ceremony. And Jennifer Hall was there, and she's been working as a senior dean for the medical school, but she's also a family doctor. And, she talked about the principles of family medicine. And, I've heard them, everybody that's a family doctor, if, you have to recite them, you need to know your competencies, you need to all that. But to her, being able to talk to these students in a way that knowing that was going to be what their purpose in the community was going to be, I felt like it was so powerful, to know that they're dedicated to that path in medicine. And a lot of people say, well, maybe they would want to do something else. Well, maybe they do. But this, I think, and I talked to a lot of them afterwards, is very exciting for them to be into medical school and to know that they have this path and to be part of this new program. So it's a big lift, and there's a lot of people, Dalhousie, Cape Breton University, the department, the government, like Nova Scotia Health, IWK, everybody has to have a part in being committed to training these folks, across our province for rural. So really, this is future-proofing family medicine for rural areas. And it's really exciting.
Nicole, are they specifically training to be rural family doctors, or are they training to be able to be any kind of doctor?
Family doctors.
Specifically family medicine. Yeah. So that's
their medical school will be the same in that there's nothing specific in medical school other than they are attached to a practice.
But the intention is that they'll go into a family medicine residency afterwards and practice as family doctors.
Yes.
And so I think this is only one of two schools currently where that's the case. Yourselves and I think Simon Fraser University was also opened up with that intention. So very unique and really, and I mean, I think also this is in a rural part of the province, and we know that training in rural areas can help with rural retention. And so really wonderful to kind of follow that along over the next few years and see how it goes. So we've talked about a lot of different initiatives that you guys have done to try and get to that vision of everybody having access to primary care, and not just primary care, but primary care that's consistent with the Our Care standard. And I wonder, do you have any data you can share with us around how things are going in terms of the impact of all of these interventions? You mentioned a little bit about some of the decrease in the number of people waiting on the Need a Family Practice Registry, but I wonder if there's other data that you're tracking or other evaluations that you have planned. How are you going to know that this work you're doing is leading to the success you want to see?
Yeah, so I think, some of the metrics take a while to move. Our goal eventually would be outcome measures, like in terms of health outcomes, rather than the process type outcomes.
Yeah.
So, certainly the decrease from 16% to under 7% of the population and moving every month down is one of our key metrics that we watch for success. Like I mentioned before, we are starting those evaluation processes, so a more local level collections of the data to know how those clinics are doing against the standard that we're kind of setting for the health home. So that's more of a qualitative evaluation type of thing. We monitor everything from how many patients we've stabilized to how many patients are coming into the province population-wise, the need of family practice registry. We monitor the number of appointments. We monitor the number of missed appointments. So there's data around pretty much every process piece that we've come in, like how much of 811 ends up in the emergency room. How could we change that? So many data points and try to focus in on the ones that we need. And one of the key ones I think that we'll be looking at too is ongoing access challenges for patients that are attached and making sure we're addressing that as well. And, we'll see, we're starting to see a bit of a shift here too with specialty care because primary health care is the foundation. You need to have the foundation fixed before you can start doing other things. So really by creating this primary healthcare foundation, it's going to enable improvements in specialty care as well, because so many specialists have been bogged down with having to provide not only the specialty care, but regular care to their patients as well. And we hear that from specialists a lot. And when we start to change that, that will be like a critical thing. The other thing is just about community in general. We've been in Canada, and I don't think I'm remiss to say this, a very acute care focused country where we focus on hospitals and hospital care. We don't really talk about healthcare and wellness and other things that we do. And I think overall our push would be that as many things as we can treat in health homes, health neighborhoods that connect for chronic disease management and other things that keep people unwell, and how we look after our seniors in the community and how we keep people out of hospital. Primary healthcare is just one piece of our work in that the larger continuum of keeping people healthy in the community. And that's really the type of things that we want to see, where people are being actually treated at home and staying at home and staying healthy in the communities that they're in. We have other initiatives going on with cancer care, for instance, and providing cancer care closer to home. That was another initiative we did. So I'm starting to see all the dots start to coalesce as we have the initiatives in every angle, and we're monitoring all that data. And, we're starting to get into what are our targets for health outcomes.
It's wonderful. I think in our care consultations, again, we heard from people how important it was to have a wellness-oriented system. And so I think that's what you're talking about. How can we bring care to people where they need it in the ways that they want it? Do you have any other advice for other provinces who are on this same journey?
Well, I think that we've waited a long time in healthcare till we're 100% sure something is perfect. And we've then people say, okay, wait at 80%. And so we've kind of taken the philosophy of, if we're 60% there, let's go and try and stop talking about pilots and having them forever and restarting them and doing the analysis, that kind of analysis paralysis, and really focus on actions. What are the actions we can do to get us to a new place? And there will be bumps. You have to go into it knowing there's going to be bumps, and there's going to be things that be ready to fail, but fail fast and change and make it better. And and you need the people behind you doing it. We needed the leadership of the health system. We needed the leadership in the government and everybody to be supportive, because That's how you actually get somewhere. I can go right back to the very first time the Premier actually came to Nova Scotia Health when he took over, and he told us a story about, seeing a gentleman out on the campaign trail, and he said to him, "Do good for Nova Scotians. That's the only advice I have for you." And and we've shared that over and over again, and that is really where we're grounded, like doing good for Nova Scotians. Like there's no other. That's the purpose.
That's your purpose.
And everybody's aligned with it. And that's, I think, if I had to tell a story of our transformation, that's what people want to do.
Well, thank you so much, Nicole, for graciously agreeing to be on my podcast today, despite your very busy schedule and all the transformation work that you're leading in Nova Scotia. Really appreciate it.
Thank you, Tara. Good luck.
It's clear that Nicole and her team are trying to do better for Nova Scotians, and they're determined in achieving their goal of everyone having access to primary care, a direction that's come directly from the Premier. I'm really impressed that they keep the Our Care standard and the patient voice at the center of their work, and that they've put in place a multi-pronged strategy to achieve their vision. So will all this work to actually have everybody in Nova Scotia have access to high-quality primary care that's in line with the Our Care standard? I don't know, but I am very hopeful. Change takes time, and my hope is that we can learn from how the reforms in Nova Scotia are really impacting care. That's going to take transparent evaluation that answers questions that are relevant to people leading change all across the country. For example, I want to know, are the physicians who are practicing in these new teams, are they actually able to care for more patients as a result of having those team members? And if so, what's the secret ingredient that really makes that happen? And how about all those access points that Nova Scotia put in for people without primary care? To what degree are we trading off convenient access for increased fragmentation and maybe unneeded health use and more costs? These are important questions that we need to have answered if we really want to build a great primary care system, not just in Nova Scotia, but across the country. I get the sense that Nicole and her team have a commitment not just to do the work, but also to learn and improve. And I look forward to learning more to really understand the impact of their reforms on care in the province. One thing that we touched on, but that we didn't explore a lot, is how primary care reforms in Nova Scotia aren't being done in isolation, but rather they have reforms underway to also help Nova Scotians stay well through community initiatives. And as we heard in our episodes on Costa Rica, it's really powerful when primary care is connected to the community. We'll be diving more deeply into the concept of supporting people to stay well in our upcoming episodes, where we'll be visiting 2 innovative teams in Canada, teams who recognize that primary care needs to be grounded in the needs of community. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by funding from the MAP Center for Urban Health Solutions, St. Michael's Foundation, and the Max Bell Foundation. Miriam Danash is our research assistant, Seema Marwaha and Emily Holton are our creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care standard and the public's vision for a better primary care system, visit ourcare.ca. Family doctors in Canada who are listening to this episode can claim MainPro credits by completing a linking learning exercise. See the show notes for more information. And finally, if you're enjoying this podcast, I hope you'll share it in your networks. It's only through enlarging the conversation about primary care in this country that we're ever really going to affect system change. And if you have cool ideas for topics or places I can visit and feature in our podcast, please do reach out at primary.focus@unityhealth.to. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.